The great Martin Luther King stood before a vast group of people and he said, "I have a dream." Now, I'm no Martin Luther King, but I'm standing before you today and I'm saying, I have a bloody nightmare. And every day that passes, I get more and more dread inside me because I can see that that nightmare is becoming a reality more and more. What is that nightmare? I see two big black clouds in the sky above me. One looks like Professor Drum and the other looks like Mary Harney. And they're shouting down at me, "We'll get you, we'll get you. We're going to centralise. Your life is not worth living. Your life is worth nothing. And we're going to prove that to you. Ha ha! We'll get you in the centralising." Yes, that is the nightmare that we're living. Because you see, I come from northeast of the country, especially a place called Monaghan. And we're the guinea pigs for the rest of the country. Teamwork have ensured that Monaghan, Dundalk and Navan will, within the next couple of months, lose all acute inpatient services and go off call for all emergencies. 15th of April, the HSE's plan for the next couple of months. There it is, all inside there. How to get rid of inpatient services in Monaghan, Dundalk and Navan, and how to get rid of emergencies going to those hospitals. Let me just say, or show you, what exactly that will mean to the people of Monaghan. In 2006, where we have accurate figures, 11,000 people attended the accident and emergency, the casualty unit in Monaghan General Hospital. Since that, a new emergency treatment room has been built and opened at a cost of €1.2 million. Of those 11,000, almost 50% of them presented in private transport to the hospital. And of the 11,000, 36% needed admission. The HSE have told us that Monaghan Hospital will go off call before the end of this year. They're hoping that it will be July 1st or at the very latest November 1st, 2008. And they have told us that of those 11,000, about 4,400 will be treated in what will be left in Monaghan, which is a minor injuries unit run by a nurse, open for a few hours each day, Monday to Friday, if they can afford it. But the other 6,600 will have to go elsewhere. They tell us, Cavan if you're medical, Drogheda if you are surgical. Now, from Monaghan Hospital to Cavan Hospital is 31 miles. From Monaghan Hospital to Drogheda Hospital is 53 miles. Cavan roads are definitely very poor. The roads to Drogheda a little bit better. But then you've got to consider the 15,000 people that live further north from the Monaghan Hospital. That will increase the distance that they have to travel from 31 to 45 or 46, and to Drogheda takes it into the 60s and sometimes into the 70s for some people. In 2003 and 2004, Monaghan was off call before for all emergencies. And during that time, we know that we logged the deaths of 17 people. There were more, but we had logged 17 in particular that we claim could have survived had they been taken to Monaghan, because even at that stage, the services were in Monaghan. But they died, they were dead on arrival in another hospital. Since then, many people, and even just 2 days ago, a person was brought into Monaghan, DOA, dead on arrival. But they resuscitated that person. They have resuscitated many over the last couple of months. They have kept them there, they have treated them there. Some of them they've sent to Dublin to St James's to get some procedures done, stents in and things like that. And those people are back living full life. But that's the facility that we're going to lose in the next couple of months. The patients, no matter what your problem will be, once all in-service goes, all inpatient goes, you'll have to go to either Cavan or Drogheda to get any kind of treatment for inpatient care. You will be far removed from family, far removed from friends, in unfamiliar surroundings. And who's going to suffer most? The young, the old, the poor, the disadvantaged. They are going to suffer most. There is no daily transport from Monaghan to Cavan. There is no daily transport from Monaghan to Drogheda. So how are people going to go there unless they have their own cars? Many people don't. At the moment, Cavan is well over 100% in bed capacity, and patients on trolleys every night of the week. That's where they want us to go. And why? Because they tell us that's a better service. We are going to give you better services in Cavan. There was an audit done last year, 2007, of the medical services in Monaghan, and it proved that the Monaghan service was better in a lot of cases, or at least equal some of the largest hospitals in Ireland for their medical care. Now we're told we're taking that from you and we give you better in a place where you lie on trolleys and corridors. It's madness, it's stupid, and it's frustrating because they're not listening to the people. And this is all centralisation, because centralisation and privatisation go hand in hand. And I'm just going to deal with the centralisation, because it's not just Monaghan. Professor Drum has told us that within the next year, 2009, they're going to spread this all around the country, to places like Ballinasloe, to places like Roscommon, to places like Ennis, Nina, Mallow, Bantry, Clonmel, Portlaoise, Loughlinstown, you name it. You can get 23 hospitals around the country where they're going to remove inpatient care, accident and emergency, maternity, paediatrics, all of those services, and make people go to the central hospital where all the services are going to be available. That, they tell us, is the only way to give good service. That's the way to stop mistakes happening, like in Portlaoise. That's what they tell us. We don't believe them. There is no conclusive evidence to prove that centralisation is the way to go. I'm going to quote, "Landmark studies by Fisher showed that high use did not mean better quality of care and outcomes. In fact, for many measures, quality and outcomes were best in the low use areas and worst in the high use areas. The less, the better." So says Donald M. Berwick, MD, who is Clinical Professor of Paediatrics at Children's Hospital and Harvard Medical School and CEO of the Institute for Healthcare Improvement. Let's look at another couple of experts, people called Martin McKee and Judith Healy. They say, "It is tempting to think that larger hospitals are more cost-effective than smaller ones because of the operation of economies of scale. However, the evidence does not back up this belief. Many people also believe that patient outcomes improve with hospital size. Unfortunately, most studies on this relationship are poorly controlled for differences in prognosis, if at all. When such differences are taken into account, the correlation between outcomes and size turns out to be relatively minor or even absent altogether." So says McKee and Healy in Hospitals in a Changing Europe. There are many other statements and major systematic reviews that conclude that no general relationship exists between volumes of procedures and outcomes. For me, there is one big question mark over the idea of centralisation. And for me, that centralisation idea and policy must be challenged. One major problem caused by centralisation is it removes equal access for all people, which we are supposed to have. And again, as I said, it's the poor, the young, and the old who are going to suffer most from this. And especially people living in rural and isolated communities. Seeking diagnosis and treatment will be postponed in order, or as long as possible, because the hospital is so far away. And that will lead to poorer outcomes and also to more difficult and more expensive treatments. Families will experience great inconvenience while the patient is cut off in unfamiliar surroundings. But the biggest problem will be the consequences of the long distance to a hospital treatment in cases of emergency. A recent study by Sheffield University showed that the possibility or your chances of survival decrease rapidly depending on the number of kilometres or miles that you have to go to get hospital treatment, irrespective of the qualifications of the ambulance personnel. Not only will people lose their lives, but communities will lose their spirit. It has been shown in many countries that the economy of an area suffers through lack of investment and the unwillingness of people to set up home in an area where hospital services have been removed. So you might ask, how can small hospitals survive? There are many examples in countries all over the world, from Australia to Canada, from Portugal to Scotland, of methods being used in order to keep access to services in rural and isolated communities, and to keep them in small hospitals where sometimes the outcomes, and very often the outcomes, are better but always equal. I would like to give you a description of a hospital that is in Scotland. It's called Belford Hospital. It serves a population of about 20,000 people, and a doctor described it as follows: Belford Hospital provides a range of urgent care services in the town of Fort William, as well as a number of smaller towns and villages. It is 70 miles from the major hospital in Redmore in Inverness. It refers patients in need of specialist services to the major centres throughout Scotland. The hospital has general medical ward, general surgical ward, a 24/7 A&E, small midwife-led maternity unit, and it also offers a wide range of visiting specialist clinics. It can be done up there. It admits only, if you take the comparison with Monaghan, it admits only 1,200 of into its medical ward every year. It does 1,900 operations, surgical, each year. But some of those surgical operations include breast cancer, include urology, include orthopedics. The physicians are trained in general medicine, and they have a heart attack unit which is very well equipped and offers basic echocardiology. So, this can be done. It is linked telemedicine with the Redmore, with the major centre, and with all the centres around. And this has been done in an awful lot of countries, an awful lot of hospitals around the place, where they link it up. Link an accident emergency in a small hospital with the teaching hospital, so that an X-ray can be passed over, directions can be given as to how orthopaedics can be attended, whether it needs specialist treatment and needs transfer on to a specialist unit. All of those things can be done as cheaply as what they are trying to do by setting up the large centres. They are going to move these services from Monaghan to Cavan, but they tell us, unfortunately, there is no money to do it. But we're going to do it anyway. So how are they going to do it? Well, they've told us. When they take the services away from Monaghan and close down those services, that's going to save money. And when they have the money saved, then they will spend it on building up the services in Cavan. Think about it. Take those services away, put them into a place that can cope, and wait for money to be saved there so that you can make this able to cope. Madness. Absolute madness. If it can be done in Belford, it can be done in Monaghan, it can be done in Roscommon, Ballinasloe, Ennisnina, it can be done all over the place. So I want to ask, who is driving this agenda for centralisation? Who is responsible for isolating rural communities? Who is putting lives at risk? Who is responsible? Well, if you want to take responsibility, the Minister of Health must take full responsibility. But then she has created the HSE without ensuring that it had workable structures, and appointed a man who has no management background or expertise or acumen, and appointed him to take charge of the largest organisation in this country with over 120,000 employees. This HSE would be a buffer between the government and the public, and it was something that they could hide behind. The Taoiseach, Bertie Ahern, and the Cabinet agreed with the strategy. But now the HSE had become a bureaucratic monster that rumbles from crisis to crisis, picking up slack here and there, but it carries on its mission to centralise and to privatise. Centralisation, sometimes euphemistically described as creating managed clinical networks, is being presented as a reasonable solution to all the ills that currently afflict us. These include the consultant's contract, the GP contract, the European Working Time Directive, doctor training, consultant specialisation, all man-made artefacts and all preoccupied with the welfare of doctors, but not the patient. If the patient is to be put at the top of the agenda, then a different policy will be introduced and pursued by government. Dr. Sally Rowan, who was a joint producer of Health Policy Research Unit, or she is a member of the Health Policy Research Unit at the Montfort University, and one of the co-authors of a report that was done on the NHS in England, and she said, clearly the government is worried by the unprecedented level of opposition to hospital closure. It seems to be trying to present the clinical arguments as clear-cut and backed up by evidence, but this is not the case. In trying to persuade the public to swallow this unpopular policy, Tony Blair may have relied on a study from his favourite think tank that was misleading and selective in its use of evidence. Ironically, spinning it this way has weakened rather than strengthened the case for hospital reconfiguration. Local communities campaigning to defend services will continue to distrust policymakers, not only because reconfiguration smacks of cost-cutting, but also because they conveniently create business opportunities for powerful interests. That's what Sally Rowan said. That's what we feel. That's how we feel in Monaghan, and we will continue to campaign. And we feel that it's about time that people all over this country realise the risk that they are going to be put in over the next few months and the next 2 years, that they should also be up on their feet and campaigning to stop this madness of centralisation and privatisation, because their lives are going to be at risk. And that is what we'll continue to do. But I do have a dream that as winter passes and those black clouds move on and those two faces disappear, hope springs eternal, that new life will be born as summer approaches with new leaders, and that for you and for me, survival will not be a matter of where you live or how much money you have. Thank you.